All right, and we are live. Thank you so much to everyone who is joining our next episode of the Myos MD Power Panel. Today, we are so excited to have Dr. Stephen Winiarski as our featured expert and guest. And today we will be talking about mastering longevity, specifically about lipid management and its role in healthy aging. So I think just in the interest of time, we will get started. So thank you so much again, Dr. Winiarski, for joining us. If you could please give an introduction to yourself and a little bit about your clinical practice.
Yeah, so my name is Dr. Steve Winiarski. I have a clinical practice. It's telemedicine called Cholesterol Doctors. And it focuses, I'm a clinical lipidologist, um, and it focuses on the decrease in the risk of cardiovascular disease, mostly. And then as we'll probably talk a little bit, it really involves so many other parts of um, metabolic systems that there's always some um, overlap between them. So you're really, by addressing one thing, you're addressing almost everything else.
Exactly. So thinking about cholesterol as like the root and the link between so many different diseases.
Yeah, I mean, what we're looking at really is the lipid profile, right? So not only cholesterol, and we can go into more detail, but when you look at the lipid profile, you're really looking at lipid metabolism, lipid homeostasis, and the transport, specifically the transport of lipids within the bloodstream. So if you take that view on it, anything that affects lipid metabolism, lipid homeostasis will show up in the lipid profile. So it could be genetic, or it could be something like alterations in glucose metabolism that many times show up first in the lipid profile, paradoxically. So you're looking at lipid profile, you're seeing some abnormalities, but in reality, the patient has some abnormality in thyroid. They may have very commonly an abnormality in lipid metabolism or glucose metabolism, like insulin resistance. So it's really a window into the function of the body.
And what initially got you interested in the specialization of clinical lipidology?
Yeah, so I've always been interested in health and longevity, even when I was younger. When I was in college, I took a class in the science of aging, and it really inspired me. And so much so that I promised my friends that I would discover a cure for aging. Unfortunately, it's probably a bit more complicated, so they may be disappointed. But it really inspired me to go to medical school, and inspired me to study family medicine, because I thought it would create this broad base of medical knowledge that would really allow me to affect the health span and longevity of my patients. It also allowed me to spend more time with my patients, which was this type of medicine that I wanted to practice. And when you meet a patient the first time, you're looking at their data, their imaging, their labs. You're creating this clinical picture. And the longer you have with them, the more you know them, the more detailed that picture becomes, and the better you're able to create a strategy to help them with either the health issues or prevent health issues from manifesting later on. And really, that was my goal. So that was my initial foray into longevity and preventive medicine. In the mid-2000s, I was at a conference, and I heard this lecture given by one of the godfathers of lipidology, Dr. Thomas Dayspring, and it really just blew my mind. The depth and the detail and what you could get out of a lipid profile. And I knew at that moment I just wanted to learn more. And that's when I started getting involved in this fascinating world of lipidology. The depth is incredible, and it's like an onion. You keep on peeling the layers, and you continually learn. So fast forward 10 years, I'm finally in a position where I can start my own practice and actually practice the kind of medicine that I wanted to and help patients the way I wanted to. So that's why I created Cholesterol Doctors.
Amazing. And the patients, I'm very interested who you're working with. Like, what is let's say if you were to identify 3 or 4 kind of patient profiles, who are the main sorts of subcategories of patients that you're working with?
Yeah, I mean, every I think patient had their own approach. So I deal with younger patients, in their 20s and 30s that are really, number one, looking to prevent cardiovascular disease. They're interested in longevity because that's in social media now. And maybe their parents are suffering from some chronic disease and they want to avoid it, so they're being very proactive. Then I have the middle-aged patient who is in the midst of realizing that they're at the peak, right? And they may start to suffer, or they're already suffering from the consequences of chronic disease and want to make sure that this doesn't progress. So they want to know what their risk is for developing disease, and if they do have disease, what can be done to halt it. And then, what I'd love to do is I'd love to deal with older patients, because frequently you can do so much by changing lifestyle, diet, tweaking treatments, that they can really get a lot of benefit from this kind of involvement in their care. Frequently, I'm sorry to say this, but I think the medical community frequently dismisses older patients as that. Well, they're old. They've lived long enough, and I find that insulting to me. And I really think that we need to be aggressive and treat 70 and 80-year-olds as aggressively as we treat younger people. Not to say that everyone needs the same treatment, but personalized medicine is very big now, and we can personalize the care that we offer these people to really improve their quality of life.
Yes. And as you're working with these different patients, are you finding different trends that are emerging? You mentioned, the topic of discussion of longevity and things like that we're now seeing more in social media. But are there any other trends that you're seeing in your clinical practice across these different patients?
Yeah, it's mostly the younger patients that are being influenced by social media and the amount of information that's out there. There are lots of people that are popular on social media, like Huberman and Attia. And Attia recently came out with his book, and that frequently gets mentioned. Rhonda Patrick is another one. There's tons of information, but it's difficult to distill it. So what they're looking for is someone to help them to distill that information into something that will help them. I mean, there are only so many hours in a day. I mean, you can do a cold plunge, you can do, sauna, you can, do this kind of diet, that. And if you were to do everything, it would take the whole day and you wouldn't have time for anything else. So what these people are looking for is what's really going to move the needle in longevity and health span. So, do the top 3 for me. What are the top 3 for me? And then we can maybe add other things. And that's what I usually recommend. It's not randomly picking one, but finding out, okay, what do I really need? What's going to give me the most bang for the buck, so to speak, in my health span and longevity, and focus on that rather than just, randomly pick stuff that may or may not help or may be trending right now.
Right. And I know it's personalized, and I'm an integrative pharmacist. So I'm all about, what's going to work best for the patients, risking the risk versus benefit ratio, and thinking about what's going to help them achieve their treatment goals. But I am curious, are there some, recommendations, like whether it's sauna, cold plunge, or certain, like let's say nutritional interventions that you see over and over again that you're recommending?
The first thing I think that the approach that I take is to look at the big things. And obviously I'm focused on cardiovascular disease. That's the number 1 cause of death worldwide, right? And I think that's the number 1 cause of disability worldwide. I would pair that very closely with insulin resistance and diabetes. So we have these chronic diseases that people mistaken as part of aging. So you'll see the 60, 70, 80-year-old in a nursing home. And you're like, well, they're old, they're going to the nursing home. When in fact, those 60, 70, 80-year-olds can be as active as they were, or almost as active as they were when they were 50, but they're suffering from diseases that are manifesting at the same time. They're at the end stage of their heart disease. They're at the end stage of their diabetes. They have, retinopathy, peripheral vascular disease, all caused from these chronic diseases that can generally be prevented if caught early enough. So I think what we start to need to understand is that, or change our mindset, that getting old is not what we perceive. What we perceive more commonly is older people with the end stage of chronic diseases, not just older people. And that's what I like to emphasize. So, and again, getting back to your question about risks and benefits, I think that's, everyone needs to look at that, right? And they need to look at the risks and benefits of whatever strategy that they choose to help them accomplish what their goals are. And something that I frequently tell patients is that any strategy that you choose, make sure that it's something that you can measure, whether it's working or not, whether it's a diet or exercise. Okay, what is that goal that you're trying to achieve? And how are you going to measure that to determine whether this strategy that you started is effective, right? So if you're starting an exercise routine, what's the goal? Is it to get stronger? Is it to increase VO2 max? Is it to get better sleep? Okay, well, how are you measuring that? If at the end of whatever trial period that you've participated in the strategy, you're not getting the benefits, then you need to look at the strategy and again, either change it or try something else. So I think it's extremely important to really not generalize and say, okay, this is going to be good for me, that's going to be good for me because somebody read it in a study, but to make goals just like you would do in anything else, and see, okay, be very specific. This is what I want to do for that. Is this helping me reach my goal? And in that way, you're not filling your life with, taking this supplement and that supplement and trying this diet and a cold plunge, when ultimately you should be doing something completely different.
Right, exactly. And, on that note, I'm very interested to hear, as, these different topics are coming up on social media, how would you say, especially like someone who's in the field working with patients every day, what are some of the new innovations that are coming out in the lipidology space? And is that something that's, aligned with what is on social media, or is it something that, patients might not know about yet?
I think it's a little bit more nuanced in lipidology, right? So I think there are two, and I think one of them maybe you're hearing more about in social media, and that's imaging, specifically coronary calcium score. So this is a simple test. It's a CT scan of your coronary arteries to see if you have calcium, and this is a surrogate marker for plaques. And typically, you would do this when you're in your mid to late 40s, maybe even 50s. And the utility of this is that it's inexpensive, very low exposure to radiation, and it will tell you whether you're developing this disease. So up until that time, what we were doing is we were creating this or putting together this puzzle of risk, trying to determine what is a person's risk for developing heart disease, right? And we'd add this puzzle, and early on, there weren't a lot of pieces to the puzzle, so we had to rely a lot on epidemiologic evidence. Now, with the advent of new lab testing and imaging, we really have a lot, genetic testing. We have a lot of different pieces to this puzzle that we can really personalize care. Adding imaging lets us know how far along is this person in developing atherosclerotic disease, because there can be a disagreement between what you see in the labs and what you're seeing in the imaging. So some people that you would expect to develop atherosclerotic disease really haven't yet, and people that you would think, wow, this person is fine, is already developing disease, and you can follow that, and you can be a little bit more aggressive if need be. So I think imaging is coming into an age where it's going to be very important in risk stratification for cardiovascular disease. The other innovation, which is, I think, more nuanced, is the development of these very powerful medications like PCSK9 inhibitors that will help people achieve LDL goals that could not be achieved otherwise. And these are people that are very high risk, have either had a heart attack, have some genetic predisposition, or are showing through imaging that their atherosclerotic disease is advanced or advancing very quickly. The other advantage is that these medications, right now, they're injectable. They're injected every 2 weeks, every month, and even there's one that's injected every 6 months. So that compliance really doesn't have to be an issue. Once you're at 6 months, you don't have to worry about taking a pill every day. You go see your doctor every 6 months, and you get your shot, and you're taken care of. I mean, you don't have to think about it, and you can focus your energies on other strategies that will help decrease the risk for cardiovascular disease. And eventually, hopefully, it's just going to be once a year.
Amazing. And so you mentioned medications as well as imaging. I can't help but wonder what the access is like for patients. Is it something that, like I as a pharmacist know, but what would love to share with our audience? Yeah. What is access like, whether it's, reimbursable by insurance? Mm-hmm. Is it something that we're paying out of pocket for? And specifically for these preventative strategies of imaging and medications?
Yeah. So, whenever you talk about insurance and prevention, it's a difficult subject. It's very, very complicated. But what I would say with imaging, especially calcium scoring, number one, you need a prescription for it. All right. And I'm working with a company, Instalab, that will help people get that prescription, right, and help them interpret the findings. Number two, it's relatively inexpensive depending on where you live. So it can, I've had patients that pay $80 for the scan, and others that, will go up to $150 or $200, in cities like maybe New York or in San Francisco. So it's relatively affordable. Unfortunately, insurance doesn't usually pay for it, even though I think it's so important in determining risk. But that's a longer conversation. Medications, of course, another challenge, especially these very much advanced medications. However, surprisingly, the price is going down. And if you compare the price of some of these medications, even if you were to pay cash, you can get coupons and everything, they start to approach what one would pay for in other forms of prevention. So we're not there yet. The prices are falling. There are going to be other treatments available. But unfortunately, as usual, the insurance lags behind the reality.
Yes, this makes sense. And apart from these two subcategories, so we talked about medications and imaging that are really some of the new innovations in the space. What about some of the other lifestyle factors or interventions that you talk about with patients who are, looking to go down this road of how can I improve my cholesterol levels to then improve my overall health span and longevity?
Yeah, so there are, I see really mostly you can separate patients probably into three categories. One is where they have dyslipidemia or elevations in their cholesterol due purely to genetics. That's a relatively small group. You have on the other side people who have elevations in their cholesterol or lipids, triglycerides due to lifestyle. And then you have patients that are in the middle that have polygenic or multiple genes that are predisposing them to having elevated cholesterol when exposed to a certain environment, right? And you have to be very granular when you're determining the approach to diagnosing and treating every one of these. I think everyone can benefit from optimizing their diet and exercise, especially those people that have insulin resistance that's affecting their lipid profile. One of, I think, the fundamental goals of people should be to eliminate insulin resistance, meaning that their tissues should be as sensitive to that insulin signal as possible. Usually this is associated with visceral adiposity or visceral fat. And you can measure that now. You can use a tape measure to get an idea of whether or not you're susceptible to it. You can use lab exams. So it's easy to discover, it's easy to track, and it's relatively easy to treat. The body really responds very quickly to exercise routines and diet. So it's not anything that you have to wait a year or two to change. You can change these things in weeks. So those are the two really lifestyle focused approaches that I recommend. And we can go down the diet rabbit hole as well. But exercise really should be fundamental. We've heard it a million times. There's nothing new about it. I'm sorry. It's and probably, unfortunately, I think to really optimize your health, you're beyond lipids, you're probably going to need more exercise than you would think. So, yeah.
Talk to me a little bit more about exercise. Like, what sort of movement do you recommend? Is it high intensity, low intensity resistance training? Mm-hmm.
Yeah, I think there has to be a mix, right, between high intensity and low intensity. When you're working different fueling systems at different intensities, and we're talking specifically about cardiovascular exercise. So, we've heard of the zone 2, LT1 zones, right? So you're working a particular fueling system there. And then talking about VO2 max, you need that high intensity. You need to visit the extremes in order to maintain that VO2 max at an elevated level. And VO2 max has been correlated to longevity and health span. As we age, our VO2 max starts to go down, right? You can attenuate that curve by continuing to visit these zones of intense exercise, right? The body will adapt, right, to the best of its ability. If you're never at those high and you're just doing like zone 2, sure, that system that fuels zone 2 is going to develop and it's going to be fine, but you're going to start to decrease your VO2 max and your capability to get up there. So it's important to do both, right? And I think it's important to do longer sessions of zone 2, right? So finding some time in your weekly schedule to spend maybe 45 minutes an hour in zone 2 instead of just visiting maybe for 20 minutes. Some people may argue and say that walking is fine, and I think it is. And I think you can get a lot of benefit from just walking. But I'm talking about those people that want to push it to the next level to optimize health. One of the things that you can do is spend that time at zone 2 for longer than you would anticipate.
Yeah, this makes sense. And speaking of optimization, what do you think about, the biohacking space when it comes to, managing lipids and cholesterol? Would love to hear your take on this.
Yeah, so we're talking about kind of the Brian Johnson space, right?
Yeah.
Yeah, so it's really interesting, and I think it's an interesting way of approaching it. I support it as long as you understand the risks and the benefits, for sure, and that you're able to measure the success of whatever strategy that you select. So Brian Johnson is very much a tester, and he wants to make sure that whatever intervention that he does results in some benefit. Now, the one thing that he uses a shotgun approach, so he does a bunch of different things. So it's hard to tease out exactly which one is giving him the most benefit. Probably it's his very strict diet and his exercise routine that's probably giving him the bulk of the benefits. And I'm sure there are some other supplements that are more important than others. So I think there are definitely supplements that have been proven to lower LDL cholesterol and ApoB. There's berberine, there's bergamot. Red yeast rice is actually a natural statin. It's the yeast is called Monascus purpurus, and it produces monocolin. You probably already know monocolin K, and that's the exact same chemical found in a statin called lovastatin. So these are all possibilities and that are effective and proven to lower LDL cholesterol. And the lipidology world is starting to look at lifetime exposure to LDL rather than certain levels, right? So if you look at a graph and every year your exposure to LDL goes up, right? And eventually you'll reach a threshold at which your risk for having a clinically significant atherosclerotic event like a heart attack or stroke goes up dramatically, right? So that probably averages around 60, 62. Right? So we can do two things. We can adjust that threshold either up or down, right? So you can start smoking and have diabetes and that threshold goes down. So you'll cross that threshold earlier with lower cholesterol, right? And so that's why you hear people, well, his cholesterol is only 100, but he had a heart attack. Well, where was that threshold, right? Or you can increase the threshold by not smoking, by exercising, by eating right, by avoiding insulin resistance. The other thing you can do is decrease your exposure to LDL, right? You can do that with diet, you can do it with exercise, you can do it with supplements, and you can do it with pharmacology. So it doesn't matter. The ultimate goal is to keep those two lines from meeting or crossing, or at least delaying it past what you would usually expect a normal lifetime to be. So maybe 80 or 90, right? And then, that's something that won't affect you during a normal human life. And, that may change as we're able to push human longevity a little bit more. And that becomes even more important because these things are separate from our cellular ability to live longer. Right. So say we manipulate it and we're able to live to 125 or 130, then it becomes even more important to prevent chronic disease for a longer period of time.
Right. Yes. Amazing. Yeah. Thank you so much for sharing. I can't believe we're almost wrapping up or about to wrap up, but I wanted to ask you one last question about, healthcare providers that are listening to this. What's the one message you'd like them to take away about, clinical lipidology and how it can really impact patients?
I think the main misconception or maybe challenge is that clinicians look at the lipid profile as something separate from everything else. So, the cholesterol is high, so we have to treat cholesterol. And really, it's just a picture of lipid homeostasis, lipid metabolism. What is it? I encourage them to look at it and try to interpret what is going on here, right? And is this something that I need to treat directly, or do I need to look elsewhere to find out what's influencing the lipid results? So yeah, that's what be a little bit more holistic with the lipid profile. And really holistic with cardiovascular disease prevention.
Absolutely. And how can we think about this from a whole person perspective?
Right, exactly.
From a holistic perspective, and not putting these singular disease states in buckets or in boxes on their own. Yes. All right, wonderful. Well, thank you so much for your time. If our listeners want to learn more about you, where can they find out more information about you and Cholesterol Doctors?
They can go to the website, cholesterol-doctors.com. My Twitter handle is Stephen Winiarski, and that's the only social media I really interact with. So
amazing. Yeah, thank you so much again for your time and for sharing your expertise.
A pleasure.
All righty. Until next time, thank you very much. Bye-bye.